So welcome everybody. Welcome again to another Kern County Breastfeeding Coalition meeting. My name is Jasmine and I'm the co-chair, one of the co-chairs for this coalition. I also want to introduce Janet Barrett. She is the other co-chair for the coalition. And we have brought you today two amazing presenters. We're going to go ahead and start off with the first being the CEO for Baby Friendly USA, Eileen FitzPatrick. So Eileen, when you are ready to go, you are more than welcome to share your screen, and the floor is yours.
Eileen, you're muted still.
Thank you. That was a really mistake. Thank you very much. So thank you very much for the invitation today to speak with you. I'm very excited about it. I so enjoy doing these interactions with Breastfeeding Coalition. So I hope it's informative and that we can have a very interesting discourse at the end. So I am employed by Baby Friendly USA, but I have no other conflicts of interest to reveal. I'm hoping at the end of this presentation that you'll be able to describe the process of Baby Friendly if you're not familiar with it, that you'll be able to evaluate two ways that Baby Friendly designation in the 10 steps reduces breastfeeding disparities, and that participants will be able to compare the step 10 post-discharge support resources and assess their effectiveness. So I have a couple of slides on that, and so we'll take care of that at the end. So I always start with this because, you know, babies are born to breastfeed, and I'm sure we can all agree on that because of the field we're in. I'm sharing this slide because this is a CDC graphic, which I like, but I want to highlight this benefits for mothers. There was an interesting publication just in the last few months by authors from CDC that looked at a national survey that found that less than 20% of people responded that breastfeeding reduced the mother's risk for these various diseases and ailments. And I think that's a huge issue in the United States, that there's a lack of understanding of the benefits to the mother, that and from a chronic disease perspective. And again, I'm a epidemiologist by training in public health. And so I think it's so important for us to ensure that our patients and our populations understand that the benefits to mothers are also very significant. And it was just, you know, again, just a recently published study. So the Baby Friendly Hospital Initiative has been around for quite a long time. It was originally developed in 1991 to codify the practices that would support breastfeeding, and those are the 10 steps. And this is a World Health UNICEF poster graphic. There's also individual posters for each of the steps if you're interested on the World Health website, and they have them in 5 different languages also if you have a need for that. The 10 steps, and again, if you're familiar with these, you know, that's fine, but I just wanted to go over them very quickly. These are the 2018 revisions by World Health and UNICEF, and these are the critical management procedures. And the International Code of Marketing of Breast Milk Substitutes was not originally included in the 10 steps. It was kind of an extra step 11, and it's now step 1A. The code is crucially important. World Health UNICEF just did a report. It's 40 years old, the code is. The US does not have any enforcement of the code, and really Baby Friendly USA is the only organization that requires compliance with the code. So I think that's important to think about. But the digital marketing now of breast milk substitutes is pretty insidious. And in some cases, on social media, it's kind of unclear that a blogger or a influencer has been paid by a formula company to promote some of their products. So I think that digital marketing directly to consumers is a bit of a challenge for our field. And there's certainly other things that have impacted reduction in breastfeeding, which has dropped 1% in the last 2 years. But it's important to understand the code and the methods of these for-profit companies. It's a $50 billion industry worldwide. So 1B is have a written infant feeding policy. We understand that policy drives practice, so that's kind of where we start. 1C is establish ongoing monitoring and data management. So if you don't measure it, you can't improve it. So that's a quality improvement step. And step 2 is ensure your staff is knowledgeable and competent to support breastfeeding. So staff and providers. These are the clinical practices. So, prenatally discuss breastfeeding with pregnant women, immediate uninterrupted skin to skin, as long as the mother and infant are healthy enough. And I am going to try and use inclusive language, but I am bound to use the same language because we take it word for word from World Health. So mothers this is the way it was published. So this is the way that we refer to it. Support mothers to initiate and maintain breastfeeding. Don't supply any supplemental food or fluids other than breast milk. Rooming in, which, I'll talk about in a little bit further. Support mothers to recognize their infant feeding cues. And, for lactation consultants in the group, we know that you can't do that if you're not together with your infant, right? And so that you don't learn the infant feeding cues unless you're together with your infant. So counsel mothers on the use of feeding bottles and pacifiers, and coordinate discharge. So I will also focus on that as we move on. So hospital maternity services practice steps, there is a dose response relationship between the number of steps experienced by a patient in the hospital and in hospital exclusive breastfeeding, as well as initiation, exclusivity, and duration subsequently. So I always say you can't get exclusivity and duration without initiation in the hospital. And I think in the United States, we've done pretty well with initiation in the hospital, meaning, that the current average is 83.2% in the United States, which is a great number. The problem is upon discharge or soon after, the rates both for exclusivity and duration drop off relatively quickly. So although there's a dose response relationship, certainly the more steps, the better, but there also seems to be a synergistic impact, meaning if you do experience all the 10 steps, it's multiplicative. It's more than just the additive of the individual steps. So having those 10 steps together really, again, codifies that experience. This is available on our website. These are guidelines and evaluation criteria. As I like to say to facilities, it's the answers to the test. It has everything you need in there for your accreditation or assessment. And certainly we now have clinical review specialists available to any of those facilities that are enrolled in our program that have questions or need technical assistance. So if you are one of those facilities and you have questions, please don't hesitate to reach out. This is our pathway, and although discovery is becoming shorter and shorter, the other phases take about a year to go through. So development, dissemination, and designation. And we do have a redesignation process. It's 5 years long, and there's annual quality improvement required for each year in that redesignation process to ensure that the practices don't slide, because we know they do. Certainly from COVID, we certainly know they do when we become, distracted and busy by other things such as, major pandemic. So baby-friendly hospital in the US. This is a graphic, although it's not cause and effect. You can see that the percent live births in baby-friendly designated facilities. And this is the percent ever breastfed or initiation in the hospital. And you can see from the time that CDC first started the breastfeeding report card, that the line, these two measures are highly correlated. And you can see that you know, in 2018 and 2022, our national rates are relatively flat. And actually in the 2022 breastfeeding report card, I believe this is about a 1% drop in national initiation. And some of that was the result of COVID. COVID was not good to hospitals, and it certainly wasn't good for our population or businesses or anyone else. And so some of that is related to COVID, although we'll have to, you know, see moving forward coming out of COVID if that's still the case, if we can go back up. Just a little overview. There are 602 designated facilities currently in the United States. That translates to about 1 million births in baby-friendly hospitals. And that, again, is about 27% of all births. It's a big number. And there's about 100 facilities currently working towards designation. So at any one time, we work with about 700 hospitals. And it's a great joy to do that. For California is a big state and it has a large number of hospitals. So right now we have 89 designated facilities and with 15 working towards designation. So a little over 100 total that we're working with from California. And I'm sure you're all familiar with the California law, you know, the race to 2025 compliance. And, you know, this is, I think, great for California residents and birthing people because the concern about, you know, supporting breastfeeding. So if you're baby friendly already, you're already compliant. So I'll leave it at that. If you have any questions, let me know. Evidence-based practice from the 10 steps and from Baby Friendly USA, the highest level of evidence-based practice is achieved by that external accountability. And we do know that hospital self-assessment tends to overestimate the degree of compliance with the 10 steps. So if anybody's ever had to grade themselves, you may grade yourself a little bit more gently than maybe someone else would have. And we do know that, and you can see from this graphic, this was published in 2019, that self-evaluation of hospitals, that's the gray bars, and then the external evaluation is the black bars. And you can see that hospital self-report of implementation of the steps, and the steps are along the bottom here, they rated themselves much higher on implementation than external evaluation did. And it's significantly different for all steps, but steps 3 and steps 10. Those tend to be difficult steps. Steps 3 is prenatal and step 10 is post-discharge. But even with that, there's still a difference. The external evaluation still rated those lower, even though they're not significant. So, I mean, the idea of this is inherently biased when hospitals self-report their activities and their implementation. And again, I refer back to early in my career as a dietitian when we collected, you know, self-reported heights and weights to calculate BMI. And what happens is women tend to underreport their weight and men tended to overreport their height. So inherently those measures are biased. So we know self-report data is biased and that's okay. But certainly the external evaluation holds hospitals, maternity care facilities to a higher standard and increases compliance. And certainly the literature supports that being born in a baby-friendly hospital increases initiation, and that's 1.7 times. So that's almost twice as likely to initiate breastfeeding if you're born in a baby-friendly hospital. There's also higher exclusivity, and that's independent of demographic variables such as race, ethnicity, income, and education. So it's more equitable provision of care, and is significantly associated with exclusive breastfeeding further out at 1 and 3 months. And let's see, I'd like to share this. And this, I think, is an important graphic. It's from a study out of Johns Hopkins in Maryland. It was done in the WIC population. And you can see in the WIC population, they demonstrated that, and these dark bars, I apologize for the small print on the bottom, but the dark bar portion of the bar is exclusive breastfeeding. The gray here is mixed feeding, and the white is formula feeding. And the hash marks here are mixed feeding. So once the infant is discharged, they didn't measure individually the mixed and formula. It's all considered not exclusive. So you can see in the first, in the hospital, being born in a baby-friendly hospital, exclusivity was higher. And that's significantly different. So these two are significantly different. Then at WIC certification, it's still significantly different, with the baby-friendly hospital birth being higher. And then at 3 months, still that exclusive breastfeeding at 3 months is significantly higher than being born in a non-baby friendly hospital. At 6 months, it's still higher. It's just not significant anymore. And so this was pretty seminal work done, as I said, by Desharmy Smith in 2021. It was published, and they're continuing to do work in this population, but it certainly has an impact on subsequent breastfeeding in the WIC population. So I'd like to talk just briefly about disparity reduction. Fewer non-Hispanic Black infants are ever breastfed compared to other race ethnicities. I always like to point out that 77.3%, now this hasn't been increased in the last couple of years. When I first started this work, it was 73, 74. So that's a better number, and it is the majority. I sometimes interact with people who work in healthcare who say, "Oh, our population just doesn't breastfeed." Well, that's not the right response, because 77% here, so that's the vast majority. There's still disparities. I mean, certainly this is below the national average. There's still disparities. And here you can see Hispanic infants are also lower than white. So there are disparities, but certainly the focus has been on Black infants. And so at least in the hospital initiation, the majority of infants initiate breastfeeding. So that's a great thing, although we still do need to reduce these disparities. And we do know that with implementation of baby-friendly initiation by Black mothers is increased, and disparities between white and Black infants was reported to be decreased by 17%. And that was a paper that just came out in 2022. That's 17% is a big reduction in disparities. So important work that was done by Cheers Champs in Mississippi. So Baby Friendly USA has strategic priorities for reducing disparities. And we do know that if you don't measure it, you can't improve it. That's the seminal statement of quality improvement. We do require facilities to submit data by race ethnicity annually in a facility data sheet. And we have a patient mother survey that we've tried to make independent of hospital staff. So it's submitted electronically and by the patient without any need for the staff to interact with a patient on this survey. So the guidelines and evaluation criteria provide a standard for the equitable implementation of care. So although baby-friendly hospitals are not perfect with reduction in disparities, they do perform better than most non-baby-friendly hospitals. And so I'd like to talk in general about breastfeeding challenges, because this is one of the areas I work on regularly. And as I said, we do a pretty good job with initiation. This 83.2, that's the national average. That's in the hospital, and so that's a nice number. And you can't get any of the exclusivity or duration subsequent to discharge without having that initiation, that good experience in the hospital. That being said, as we can see, these declines are pretty steep, and they occur, relatively quickly after leaving the hospital. So this is a problem. Why do mothers stop breastfeeding early? 60% of mothers stop breastfeeding sooner than they planned. And this is data from CDC. So they didn't reach their breastfeeding intentions or their goals. So why is that? So hospital practices, we've already kind of discussed, baby friendly and other hospital practices that support breastfeeding in all patients in the hospital. Education and encouragement, that's a little bit more diffuse as far as responsibility for that. Who has that? The provider, potentially, prenatal environment. Policies or supports in the workplace, that's been a big topic of conversation and legislation. And so I have a couple slides on that. And access to community support. So I am going to talk about step 10 and discharge resources, because that is a big issue, I think, in maintaining and supporting breastfeeding so that our patients and participants, in WIC or whatever other program that you may be working in, actually meet their goals and intentions of breastfeeding. So I'll start with the workplace, and California does have a paid leave law, and they actually have had it since, I believe, 2004. So that's fabulous. There's no job protection, but there might be job protection through FMLA, Family and Medical Leave Act, which is a federal law, or the California Family Rights Act. We do know that paid leave can make a difference. My area is, and a colleague and I published this paper in 2022, that New York State paid family leave law was associated with increased breastfeeding among Black women. So it makes a difference. And it's almost, it's a little bit frustrating that, that we would be surprised by this, because we shouldn't be surprised by this. The longer you can stay home with your infant, the more likely you are to be successful with breastfeeding and continue breastfeeding. It's the return to work that we know is a challenge. So paid federal paid leave law would be, instrumental in supporting patients postpartum to continue or to meet their breastfeeding goals and intentions. So I want to talk a little bit about the continuity of care here, the prenatal experience, the hospital practices, and post-discharge. So I want to, ask everyone, hopefully you can put in the chat. I don't know, can I see the chat here? If you could put in the chat what you think is most important for anticipatory guidance of, for pregnant people. I always wonder why we don't better inform pregnant people of what to expect in the hospital, what to expect from breastfeeding, if their intention is breastfeeding. So if everybody would like to participate a little bit, what do you think is the most important things that a pregnant person should know, going into childbirth, especially associated with the hospital experience and breastfeeding? So I would love to see.
And Elaine, I can go ahead and read those as they trickle in.
Okay,
But I will say for WIC staff, we do give a class before childbirth, and it's called Let's Talk. And in the Let's Talk class, we go over, I would say one, so I don't take all of but one of the focuses is, the expectance of milk, that you may not have all your milk supplied
right.
the day, like right after birth. And then I see Janet says, babies don't sleep all night. It's normally for them to feed frequently. It's normal for them to feed frequently.
Right. Right. So frequently 10 to 12 times in a 24-hour period is frequently.
Yeah.
And right. So this idea that you're going to get, rest, especially now most women normal vaginal are out of the hospital within 36 hours, that that maybe hour or two of rest at that time of the hospitalization is not going to make any difference whatsoever. And, moms and babies are meant to be together. So, are there any other?
I did have two more. It's somebody,
yeah,
Tayana said, length of time you can be active in labor. And then Lori says, most women are unprepared to the demand of breastfeeding. Most moms stop due to exhaustion.
You're right.
And then diet, that should be maintaining while breastfeeding. So diet being
right. So I do have a couple, let's see. So, if you're the individual is giving birth at a baby-friendly hospital, kind of what to expect. So that immediate skin to skin, that rooming in, that support for breastfeeding, I think is important. And if it happens prenatally, there is some literature in there is some published research literature that shows that having that anticipatory guidance before makes the experience in the hospital much more positive. Knowing what to expect is important. So what you can request, I think in all hospitals, you have the right to request that your baby is with you. And you have the right to request skin to skin. In New York, we have a breastfeeding mother's bill of rights. And so you have the right to request whether the hospital is baby friendly or not, any of the 10 steps. You have the right to experience those. So hospitals are required to provide that if you request. Rooming in that, we just did a profile, an article on rooming in. Dr. Lori Feldman Winter was the physician who was quoted in the article, who talked about the importance of rooming in. With mammals, the infant and the mother are meant to be together, and it's stressful if they're not. So it's a normal mammalian process. And I think we don't necessarily relay that information. That doesn't mean that you can't get help from the nurses and other staff in the hospital, because I think that's what, the issue that some patients experience, that they feel they need help and they feel they can't ask it because they're taking care of the baby in the room. But that's not the case. The staff is still available to help you as you need it and should. Sleep was already mentioned. That I had a grandmother ask me recently, like, what she could do to help her. She wanted her daughter, the baby was less than 2 weeks old, and she wanted her daughter to start pumping so that she could help feed the breast milk. And I was like, let her feed the baby and you do everything else. So that's the other thing with exhaustion. If you have some kind of support but sleep is a huge issue. It is exhausting. Zombie. I remember just being a zombie as a mother of 4. My first one didn't sleep till he was 11 months old. And so, that zombie feeling is awful, but it was worth it. Supplementation, that sufficient milk supply. So having, ensuring that patients understand what that looks like. And I have, belly balls. I have a slide in 2 or 3 slides. Belly balls, I think those are really good visual aids. I know some nurses that I've talked to carry them around with them so they can share those with patients. Is there a question? I can answer a question. Danny, I think.
Hi, my name is Danny. I'm a full spectrum doula. And to just really quick on your sleep deprivation, as a doula, I always recommend clients get a cheap calendar from the dollar store, and they write out a sleep schedule, and they respect each other's sleep.
Right.
We talk about deprivation and how that affects postpartum care, the relationship, etc. So I just thought that was, and also affects breastfeeding. But if you guys also want to do that as well, just recommend that they write out a sleep schedule for postpartum, because it does benefit. I have seen the benefits, if that's okay for me to say.
Yeah, absolutely. That's great. Thank you. So where and when to get help, support. And so we do know that there's not a lot of resources in some communities, especially not a lot of culturally appropriate resources for, various race, ethnicities. So where and when to get support and help is important, because oftentimes the default. I was in a pediatrician's office a couple years ago, and someone called on the phone and said, "Oh, the mom's having trouble with breastfeeding. Is it okay to give formula?" And the pediatrician said yes, and that was it. There was no additional support provided or referrals or anything. And so we do know that there's a lack of that in a lot of communities. And the use of bottles and pacifiers. I mean, the AAP recommendation is for not to use them until breastfeeding is well established. I mean, October is SIDS Awareness Month. I'd like to, put a plug in there. Breastfeeding reduces SIDS. Certainly pacifiers play a role, but pacifiers don't trump the breastfeeding impact. So it should be breastfeeding. And then once breastfeeding is well established, which is typically 3 to 4 weeks. That was the prior AAP recommendations, guidelines, the American Academy of Pediatrics, but not until breastfeeding is well established. And it's usually by 3 weeks. And so at that point, bottles, I mean, most people, talk about going back to work and therefore wanting to start bottles right away. And I understand some of that, but it's best, lactation consultants in the group know it's best to get it well established. We know supply and demand. So we know that those supplementations, whether they're in the hospital or in one's home, that they impact milk supply. And these belly balls, this is my favorite graphic, is that, on day 1, 5 to 7 mils. So you don't need an 8-ounce bottle of formula on day 1, certainly. And you know, that perception that patients have that the baby's not getting enough, I think can be really detrimental. So it's good to know. I mean, we want to make sure that the baby is getting, you know, so that getting enough. So I don't know, does anybody have any, share any ideas? I worked on a project in New York State where trying to address that concern about the baby getting enough. Does anybody want to, you know, throw in the chat a couple of comments as to what they say to patients that or clients or participants that as far as ensuring that the mother's confident that baby's getting enough? Does anybody have any, or you can unmute and yell it out? Nobody?
Sorry, I see that Danny.
Go ahead.
Yeah.
Yep.
I always tell them baby's tummy's really small. It doesn't stretch yet. Baby's getting enough. If baby's not getting enough, they will let you know by their cues. If they have like a really tight fist while they're feeding, they're usually still hungry, hands relaxed. That means that they got enough. You know, just those little cues. If they have that sharp cry, usually it means that they're hungry. You know, if the cry is just kind of like usually that's more like comfort. Just, you know, those, just pay attention to your baby. And I just reiterate that they're getting to know each other. So just to be kind to themselves.
Exactly. I love that. That's great. And I see the book we give mothers uses fruit, grape, cherry, tomato, apricot. That's perfect as far as the sizes go. So one of the things that I did it was a CDC community breastfeeding support project in New York. We had baby cafes and we bought scales and had the mothers weigh the babies before they fed them and then weighed them afterwards. And they could see that the difference in the weight, and that had very impactful effect on the mothers, as far as they felt much more comfortable that the baby was actually getting food. So certainly we know that the baby's gaining weight and things like that, but it's that more immediate gratification of knowing like, oh yeah, they're heavier. So they definitely got milk. Was an interesting implementation of kind of an idea that was very successful. So as far as post-discharge, and we can talk a little bit about the post-discharge supports, this is a challenging step for hospitals, and they're not all that successful in a lot of cases. So each mother should be linked to lactation support resources in the community. We do require that they submit a written description of how the hospital fosters that establishment and coordinates with mother support groups and other community services. And certainly there are hospitals that do this better than others. Written, printed, or electronic infant feeding information that is distributed to mothers before discharge. We can talk a little bit about that because, you know, traditionally we've seen a lot of print, which is not necessarily very effective. There are more apps now. You know, there's some issues with apps, but some of them are very, very good with evidence-based and supportive information, and they're available when, you know, the mother patient has the opportunity to read that. So resources for lactation, and I know we have Danny, a doula. Doulas are trained in lactation, and you know, some to a greater extent than others, but certainly doulas and WIC peer counselors, baby cafes. I think there's only 4 in California, according to the Baby Cafe website. They're not the answer. They're only open usually a few hours, a couple times a week. But we do find that for some populations, I know in New York, there's some WIC offices that have baby cafes. They did them virtually during COVID. That peer support seems to be very important. And so that's a possibility for some communities. IBCLC's high density IBCLC support is associated with increased breastfeeding by low income mothers, and services are cost effective. And that's if they have access to an IBCLC, especially if they have access to an IBCLC that's congruent with their, you know, culture and race, ethnicity. It's even more effective. A lot of communities don't have them. And, you know, as far as how the IBCLC gets reimbursed for services is problematic in a lot of states. And I don't know what the California state laws regarding insurance reimbursement for IBCLCs and who has access to that. But breastfeeding medicine, there's a hospital recently that I talked to that has a breastfeeding medicine clinic, and they refer all high-risk patients to the clinic, and they're seen within, I think, 3 days post-discharge to ensure that breastfeeding is going, successfully. And it was a brainchild of a physician there, but it's shown to be really effective in sustaining breastfeeding in those high-risk patient infant dyads. So I'm going to go through this very quickly, but this was, we had a patient survey that was done. I mentioned it earlier in the presentation. And this is a profile of the 3,600 surveys so you can see that 59% was exclusive breastfeeding, but nearly 90% was getting some form of breast milk of these patients in baby-friendly hospitals. And I have to laugh when I look at this graph, because 64% of those 3,600 individuals said they got paper printed handout. So who knows what happens with a paper printed handout? Where does that end up? Either lost or in the trash. With my first child, I don't think I opened that bag I got from the hospital till I was 3 months past discharge. So paper handouts, we know printed handouts are common, but they are not very effective for patient education and resources. Apps are becoming more popular. You can see it's a small, this survey was primarily done in 2021, but apps are becoming much more popular and have information accessible when the patient, you just have to be a little cognizant of the messaging in these apps. Warm line number, that's a good thing. Support group, home visit, lactation consultant. So quite a few were referred to a lactation consultant, and other right here. A lot of these write-ins for what other was WIC. And that's great. I was so happy to see that, because the resources to be referred to WIC with the breastfeeding support, most WIC programs is fabulous. But this is a little concerning, and I'm hoping that we see a little bit more decline in the paper printed handout, and see an increase kind of in the apps that are more user-friendly. The printed handout, I mean, if it does have QR codes and other ways that patients can access the information on their smartphone, that I think is a good way to go about it. But just the paper, lists of phone numbers and addresses is not very effective. So a lot of electronic and digital resources. This is again an article that came out in 2019, so it was pre-COVID. But resources need to be flexible. Patients and clients do prefer Dr. Google to printed pamphlets. It's a little scary. You don't always get the correct evidence-based information from Dr. Google. But if they do have an app that has been recommended by their healthcare provider, that I think may address some of this Dr. Google issue. Engage content that just pops up on your phone. I get concerned about formula company ads or promotions that just pop up on your phone, depending on what your search is. So I think that's something to be aware of. And the formula company websites that sometimes pop up as having breastfeeding information are very deceptively negative about breastfeeding. So you'll see they talk about sore nipples, they talk about the other problems that can occur instead of the more positive aspects of it. And then, but despite that, although helpful, digital resources are insufficient to meet a pregnant woman's needs for social support. So that's social support. So whether that's a peer counselor, a doula, baby cafe, whatever that is, a family, there's some birthing people are the first in their family to breastfeed. And that's, it's hard if you don't have that social support. And then factors that influence infant feeding at hospital discharge among urban socioeconomically disadvantaged women. And I like to say this because I'm such a big fan of WIC. I want all community organizations involved in breastfeeding to partner with hospitals, whether they're baby friendly or not, because I think it's the right thing, and we need to support patients post discharge. But WIC has a specific role, and I love to see WIC peer counselors in the hospital. It's, you know, it's an individual agreement that has to occur at the hospital level, but it certainly is possible. The only thing that Baby Friendly requires is that the individuals that represent WIC don't provide, you know, formula EBT benefits to an exclusively breastfeeding mother in the hospital. So you want somebody trained to support breastfeeding, and you don't want to provide even the idea of having that formula accessible on your EBT card can undermine breastfeeding. So we just like to make sure that those peer counselors and other WIC providers are there, you know, supporting those exclusive breastfeeding mothers, because we work so hard to get them to that point. So it's important to remember that. So communities and hospitals include hospitals and community breastfeeding coalitions, which I'm not sure if there's any hospitals here, but that's a great thing to do. Provide community resource materials to hospitals. So I know somebody, Jasmine was at a coalition meeting that I did, I think I don't know, was that 6 months ago, a year ago? And there was one organization that had provided their QR code to the hospital so that they could link directly to the resources that community organization had. If you can track breastfeeding according to Baby Friendly hospitals compared to other, that's great. Not everybody can do that. I know in WIC in New York, we can't do that. Provide continuity of care in your community and support and encourage Baby Friendly hospitals if that's appropriate. So, but the continuity of care is important. And I do want to highlight this because I feel like a lot of people are not familiar with this. This is a blueprint for communities that was done by the U.S. Breastfeeding Committee and NACCHO with CDC funding to support breastfeeding. They have a lot of recommendations. I shouldn't say a lot, 7. If you haven't been to their websites, they have webinars on implementation of each of these recommendations. And they also have had funding. So they've had communities actually implement these recommendations. And again, they have webinars that demonstrate how it's done and their success. So this is a great resource if you're not familiar with it. I think it will move that community support a little bit further, that needle a little bit further. And then, so just to conclude, you know, Baby Friendly hospital designation, I truly believe it is the highest level of evidence-based practice because of the accountability, and hospitals will tell me they won't do it unless we make them. So it's kind of it's kind of a mutual you know, push me, pull me relationship, and we work very closely with hospitals, and they you know, it's not always easy, but they do a great job. Baby Friendly hospital designation does increase initiation and exclusivity in the hospital and subsequently, as I showed that slide about WIC, the WIC population. It does reduce breastfeeding disparities. It does provide more equitable care because of the accountability. That being said, you know, systemic racism exists everywhere in healthcare, including in maternity care, and Baby Friendly hospitals are not perfect, but we are working towards and committed to reducing disparities in Baby Friendly hospitals with some of our initiatives, so in our quality improvement efforts. And then partnerships between hospitals, you know, regardless of whether they're baby friendly or not, between hospitals and community organizations is crucial to the successful support of breastfeeding and reduction in disparities. So I think that's really important. And we reduce breastfeeding disparities and we reduce health disparities. So I think long-term, it's so important for us to remember that. All right, I can stop sharing. And I'm happy to answer any questions. So if anybody has any questions for me. I went through an awful lot, you know, quickly. I did.
Do you have any like brochures or anything like that that you could pass along to us so we can have those?
So what kind of material are you looking for?
Like the well, you noted, you mentioned like designated baby friendly hospitals. So if you have those, that way we can share those with someone that we know.
Yeah, I can put that. They're listed on our website. So let me Okay, oopsie. We have an A to Z map, so I'll put the link in the chat so that if you go to the website, it'll tell you by state which hospitals are baby friendly, and so you can look through them. California's again, there's 89, so to look through all of those, but our website has other information on resources for parents and things like that. So if you're looking for something a little bit more specific, like a reference, I can certainly provide that. I can give it to Jasmine and she can send it out if she's interested.
Definitely.
If she's able.
Yeah, and I do have a question in the
Okay.
chat, a few. Jose asked if hospitals are. He did a research in Fresno and found that there was hospitals encouraging families or birthing parents to stay in the hospital and not leave until they have successfully latched and are breastfeeding. Is this a policy that all hospitals have to uphold, or does it all depend on the hospital and how much they support breastfeeding?
Yeah, so that's a great question. It is not a baby friendly policy. We don't dictate how long the patient stays because that's a hospital specific decision. That being said, I think that's a great policy because and it kind of is similar to what the hospital in Michigan I was just talking about as far as their breastfeeding medicine clinic. Like anybody that they think might be having trouble that maybe didn't latch well in the hospital, they refer them to the clinic. So hospitals implement baby friendly in various ways. We want hospitals to implement that in the most patient friendly way. That's not always the case. And we do try and address that with facilities. We certainly have on a regular basis, but it's not a policy as far as how long they stay. But if a patient, so in a baby-friendly hospital, the nursing staff should have the knowledge and expertise to support, breastfeeding initiation, kind of on a basic level. If there's any problem, so if the baby is not latching and there seems to be a problem, they should be referred to the lactation consultant. And so they should have a lactation specialist at the hospital. Again, we don't dictate how many or what hours they are. And sometimes hospitals don't schedule them on weekends when, if you have your baby on a weekend, then you don't get to see the lactation consultant, but, all of those things. So it's so crucial for patients and mothers to be provided with resources like, okay, if you are still not being successful a day or two later, then you need to know where to go to ask for help. So I think that's where it is. So I think it's a great, intervention to keep those mothers who are at higher risk. But again, it's not a policy, but there are other ways you can potentially catch those that may be having challenges, after they're discharged. Hopefully that answered your question.
Thank you. Thank you for answering that question. I do have a comment in the chat. Janet says, in Bakersfield, 3 of the maternity hospitals are already baby friendly. And I believe she is referring to Kern Medical, Memorial Bakersfield, and Southwest Mercy, which are all under the Baby Friendly USA. They're all
Yay.
Yeah, they're all under.
Yay.
And the great thing is that your website actually has them listed on, where you can find your local baby friendly hospitals. And I do want to mention that Adventist Health, formerly known as San Joaquin, is currently working on becoming baby friendly. They're, I believe, at the last few steps. And Richcrest Regional, they're going a little bit different route. So I know you mentioned that Baby Friendly USA is one of the routes, going through your system, or they can also implement model hospital policies.
Policy. Yep.
Yeah. So and I see there's one more. Yes. Jose says, thanks for the explanation on the process. Yes, I did.
Sure. That's great. That's great. Any other questions? So I appreciate all the work you do to support breastfeeding. I love talking to breastfeeding coalitions. It's really a mission of mine to ensure that we do the best we can to support any of the individuals who want to breastfeed, that they meet their intentions and their goals. And so we'll get there. We'll get there eventually.
Yes, and thank you so much, Eileen, for everything. If there are any other questions that trickle in, and we're not able to answer them, we can definitely reach out to you. I know you provided us your email, your phone number, so we can reach you that way, if that's
Okay.
all right.
Yeah, no, that absolutely. So I'm happily and I can put my I can put my email in the chat if anybody has any questions. And we provide a lot of technical assistance. So if you have any questions or need additional resources, let's see, make sure I spelled it correctly. You're more than welcome to email me. Okay. Thank you so much for the invitation to speak with you today. It's been great. And I will sign off now. Thank you.
Thank you.
Yep. Bye.
Great day. And I did want to mention she has so many more talks and she gave me a list of them. So at our next meeting registration for next month, I'll be sending in one of the questions would be, what kind of topics are you all interested in? And I'll be listing the topics that she presents on. So then just keep your eye open on that. And I do want to mention real quick, you know, she mentioned local resources. And as you saw, the amount of families that are initiating breastfeeding in the hospitals is really great, you know, percentage as far as here in California or throughout the United States. But, you know, it's when they're discharged is when there's difficulties and they don't get the same support that they do in the hospital. So I do want to, let's connect with each other. Let's, if you guys could scan this, can you guys all see my screen, first of all? Yes, thumbs up. Can you guys, yeah, great. So this is a contact list. I try to update it as you know, every month as we get new participants. And if I did get your name wrong or your anything, your phone number, your credentials, please let me know and I will update that for the next month's coalition meetings. But I will keep this, I will do this on a monthly as we meet, so that way everybody's connected with one another and we know what organizations are representing or which people are representing what organizations and hospitals. I did highlight the hospital. So if you open it up on your phones or I will also put it in the chat, but if you open them up, you'll see that the hospital contacts are highlighted. So if you'd like to connect with one of them or have questions, you know, you have that they're highlighted for you. So I will put that in the chat in a little bit. Without further ado, I will turn it over to Kimberly and I'm so sorry, Kimberly and Katherine. They're from Kern County Public Health, and they're representing the or they're in charge of the car seat check program. So if you're on the call, please take it away.
Hello?
Yes, we can hear you.
Oh, okay. So my name is Kimberley. I'm here with Katherine. We're with Kern County Department of Public Health, and we're the car seat check program.
And actually, Kimberly, I don't know if it's everybody, but on my end, it sounds a little muffled and it sounds a little bit low. Is it possible that you could get closer to the mic, or I know.
Can you hear me better now?
Yes, I
Hello?
think yes, that's way better. Thank you.
Okay. Okay, so my name is Kimberly. I'm here with Katherine. We're with Kern County Department of Public Health, and we're with the car seat check program. For the next slide, I'll talk about the Kern Kern Public Health and Safe Kids partnership. So Kern County has teamed up with Safe Kids Worldwide to form Safe Kids Kern. Safe Kids Kern's job is to help prevent kids from getting hurt. Kids, the main reason why kids get hurt is due to car accidents. They can get severely injured from car accidents. So our purpose is to provide free education to residents of Kern County on correct installation and use of car seats while they ride in vehicles, as well as safe seating options. Kern County Public Health is deemed children's safety as a top priority. Health equity is important to us, and this is a program that attempts to narrow the disparity through education and other resources.
Hello, I'm Katherine. So now we'll go over what qualifies someone to receive any services. So our eligibility requirements include the client must be a Kern County resident. So with that, they must provide proof of residency, either a bill with their name and the address that they provided us with through the referral, or it could also be their ID. They must also sign our liability forms before we provide any service. And then only legal guardians can ask for car seats. So we do provide car seats if in inventory. It just depends on how much we have. With that, we also have car seat checks. So we also do inspections, and that is open to everyone. So it doesn't have to be a legal guardian. And also with that, the client must have not received a car seat from public health within the last 3 years. And if they have, then we would just let them know that we cannot provide them with one at this time, and we would close out their referral. And for pregnant moms, we oftentimes just refer them to Bakersfield Pregnancy Center, just because they offer way more services than we do. And lastly, they must meet the low income requirement. So car seat checks. So the way our car seat checks go is we get a referral from them that is submitted through Kern Public Health. So we call them, we schedule an appointment. They come in and they sign the liability forms and the car seat check forms before we touch any car seat or get involved in anything. And after that, we inspect car seats for structural damage, any expirations. We also look at manufacturer information to see if they have been any recalls for that specific car seat. After that, we observe if the car seat is being used properly. So we look at the location, whether it's in the middle or the rear. We look at height and weight limits to make sure that the child is within the height and weight limits, depending if they are rear facing or forward facing. After all that, we do discuss this misuse that have been observed with the client. We let them know the importance of having it the proper way, and just let them know why it's safer this way than the way that they came in. And then this right here is our flyer right here. So it has this kind of the same information we discussed. There is a QR code in both English and Spanish that they can fill out the referral for. For car seat, so again, that's only if it is in inventory. It's the same thing, but we just do, we offer a virtual presentation online, and after that, they will have to complete a quiz, which they must pass. If they don't pass on the first try, that's okay. They would just have to come in for an in-person presentation and a quiz. And then depending if they pass or not, and if they do, we would set up an appointment, and then they will come in and we will teach them how to use the car seat, and then they will go with the car seat. Yeah, that was basically it. It's a very small presentation. Here's our website, kernpublichealth.com. You can search up car seat program. If you want to refer any clients, it's in both English and Spanish. And if not, you can always provide the phone number on the screen and just ask for the car seat program, and you will be transferred to either I or Kimberly. Any questions?
I don't see any questions right now, but I do have a question. Oh, I do see a question. Yes, the flyers will be sent out. I will be sending those out with the follow-up email after this meeting. And my question was, so some employees at the hospital had mentioned, they have a family that has little to no resources, and they weren't, they weren't prepared to be able to take home a baby after being discharged because they do not have a car seat. In those emergency cases, would you also refer them to, like, let's say, Bakersfield Pregnancy Center, or are there other resources that can help in these emergency cases where they don't have a car seat?
Yes, so we have gotten referrals as well where the mom is about 2 weeks from their due date, and normally we do help them out with a car seat. And we've also had situations where they were already in the hospital and already gave birth, where we were able to also help them with a car seat. It just depends. That's on a case-to-case basis.
Thank you so much for answering that question. And
I have a
Oh.
question for that actually. So sometimes when I'm doing the prenatal classes, patients ask about where they can get a car seat. It's obviously not an emergency situation if they've got weeks to go before they deliver. So would it be better to refer them to you or to the Bakersfield Pregnancy Center? Who's likely to have more?
Yeah, we usually refer them to the Bakersfield Pregnancy Center. On top of that, they do offer more than just a car seat. They can offer their crib or clothing and whatever resources they have.
I knew they had other things. I just wasn't sure if they had car seats as well. But
Yeah, they do have car
they
seats.
do. Okay, great. Thank you.
You're welcome.
And I do want to disclose, because a lot of people they believe that Bakersfield Pregnancy Center can just give them, right off the bat. They come in, they go home with a car seat. Depending on, it's case by case, but at the same time, I believe they have to take their classes, and they receive baby bucks, and then these baby bucks they can get them, like, reimburse them to then get items from their like donated items like the crib, clothing. But yes, Tayana makes a great point. We will have Erin presenting very soon. We're looking at either December or January for her to present. So we'll keep you guys posted on that. But thank you for bringing that up. And any more questions, comments? I hope, well, thank you. Thank you again so much, Kimberly and Katherine, for, taking time out of your day to present and put this together. I think it was wonderful. And I will be sharing out these slides with your permission to the coalition, if that's okay.
Yes, that's perfect. Thank you.
Perfect. Thank you so much. And if you'd like to
Hi.
stay. Yes.
Oh, sorry, real quick. Just Deanna Lara from Clinical Services Autism and Family Life Program. I just want to go on here real quick and just remind everybody, if we are going to be referring our clients to the pregnancy center, once again, just to give our clients a heads up that it is heavily based on religion, just so that they're not surprised when they go there. Because I had a few. So just a heads up.
No, thank you, Deanna, for mentioning that. Yes, that is very true. They are faith-based, and yeah, just something to keep in mind when you are referring patients, participants, clients. Great note. I do also want to let Katherine and Kimberly know if you'd like to stay for the rest of the coalition meeting. We are going to be going over like roundtable, so everyone's going to have opportunity to talk a little bit about the program, if they have any announcements, and share any resources for those in this meeting.
Okay, thank you so much.
Alrighty, so moving along. Oh, here are the flyers in English and Spanish. And then moving along, can you tell I love QR codes? Here's another QR code for the Kern County Breastfeeding Resource Guide. This guide is throughout Kern County. we try to put information that will benefit the greater population, those especially in the low income, to those in the low income, the ones that we are really desperately in need of assistance. Though there are some resources on this form that are insurance based, or you have to be part of their, you have to be eligible. So for example, WIC, you have to be a participant or eligible for WIC to then get the resources or the services from WIC. Another one, if you delivered at Adventist Health Hospital in Delano, they have a lactation consultant on staff, and you can communicate with the lactation consultant via text message. But again, you would have to be a patient of theirs. So there are some, caveats to what resources are available. But again, if you open it up, if you do not have it, it's in English and Spanish. And please, please, please share it out to all your clients, or those clients that are seeking information like this, or even if they don't necessarily need it, but they know somebody that does, please share it out. Our goal here is to have this resource guide at all the hospitals, all the birthing hospitals. And I know that Elaine was mentioning that printed copies, they tend to go, missing or in the trash, or they don't see it until, months later, which is why we have a website that our participants, patients can also visit. And our website is linked on the document. And I will put it in the chat for those of you that haven't had an opportunity to check it out. We translated it to English and Spanish, and hopefully we will translate it to more languages. So coming soon, we're thinking of getting the resource guide also translated to Tagalog and other languages that are commonly used here in Kern County, to then make it, make these resources equitable for here, for our county. And I believe this is the last slide, so I'm going to go ahead and stop sharing. And if you guys have any questions or want to make an announcement, please feel free to take yourself off mute, and we can go around and do roundtables now. And if
I can go.
Thank you.
So my name is Tiana Mitchell. You guys probably already know my name, but I'm with Kern County Child Support, Program Specialist with Community Development. So right now we're actually doing Socktober, where we it's mainly in-house fundraise, but we have our staff bring socks in, and at the end of the month we drop them off to Jameson Center for the children there. So if you're interested in participating with us, feel free to, you can email me, or you can call me. I can come pick up the socks, or you can drop them off, and you'll be part of that group that helps us donate those socks to the kids.
Thank you so much, Tiana. I know that, we just got back from lunch not too long ago, and, we just went through 2 presentations. So if you, if later on you remember, hey, I want to share this out to the coalition, feel free to email me, and I will include it in the follow-up email along with the recording. And I do want to give a quick, I mentioned this last meeting, but here, so a little bit aside from, facilitating these meetings, I work with healthcare providers and also community partners, and I've created these posters. I don't know if you could see them. I can also put them in the follow-up email, but basically it's it's a way to refer your participants, your patients, your clients to WIC. It goes over what WIC offers, what breastfeeding support services, and it also has each of the WIC agencies, so Clinica and CAP-K WIC, and there's a QR code. Because again, I mentioned how I am a QR code, savvy person. I put it in there so those that would like to get additional resources, it takes you to local breastfeeding resources, in Kern County. So it takes you to our website. If you're interested in having them at your clinics, at your offices, please let me know and I can have them mailed out to you. I can drop them off. We do have frames to have them nice and framed up in your clinics. They are limited, but those that do serve the pregnant and infants, we are prioritizing those agencies just because of availability. But as soon as we have more, we will offer those as well. So let me know. And I do see some comments in the chat. So yes, I will connect with you guys. Any more questions? I do see some CalFresh reps. So if you guys want to come off mute and let us know, I know you guys have like a monthly or also a community collaborative meeting. Sorry, I can't think of my words.
Well, I am CAP-K, CalFresh Healthy Living. We're looking forward to working with some clinics. Our services consist of nutrition education. If you have the room and you would like some mothers to, receive our curriculum, we have, 3 class series, 5 class series, last from about 60 minutes long. We'd be more than willing to do that. If you have the space, we can come there and provide classes. They do include food demonstrations. And one thing in the future that we are, there actually is a toolkit, a curriculum for mothers, and we just haven't used it yet. So if with your help, we can get that started. We can have a nutrition ed class for mothers that it's, designed for pregnant women to give those classes, to those nutrition classes for them, and to, feed the child as well. But we are looking forward to food insecurity referrals in the future next year, and that'll be done. We're hoping to do an assessment before that. That's what we're looking forward to with the staff and the actual clients that go in there to see if it's needed. If you're interested in that, the food insecurity referral provides your clients with community resources such as locations for food pantries, locations for food distributions that are funded by our food bank. And that's all free food throughout the whole county, actually, not even just Bakersfield. So that's a really good incentive, and it would help your clinic battle the food insecurity that's going on in our county. A lot of parents, a lot of families are dealing with that, not having enough food in their household to provide for their whole family. So that's what that insecurity reform was for. So it's a long process, but it's for a good cause. And there's an assessment process just to see if we need to do it at that facility, at your facility, if it's needed.
Thank you so much, Jose. If you could please send me that information and I can send it out to everybody. I know there was a few people interested in that. And I do have a question for you. In regards to the curriculum of, prenatal nutrition classes, how could we get that off the ground, and like what support do you need from us?
So we get all our curriculum through Food and Nutrition Service, and it goes down the chain, from overseeing agencies to state implementing agencies, and it goes to My Plate, and then we get our curriculum, My Plate for mothers. So how that would get started is if a clinic or an organization was interested and they have, they have mothers say that they would show up to these classes, we would just contact the I think the FNS asked them for a slide presentation of the curriculum, and then we'd alter that and we just present it. So it's really just, as soon as somebody would like to be interested in it, and the response time of that. But we are looking forward to giving classes next year. So we're going to wait off, it's something to look forward to now. We probably should ask CDPH, California Department of Public Health, to help us get that that curriculum and that format and those slides, everything figured out, before we start giving those classes next year, if any of you are willing to do it. I do see that the information for that, I could put my email, and then I could send you a link to that that curriculum. If you want to do it that yourself, that's fine. We could still do it. It's just, these mothers do have to get proper nutrition education classes, because, why not give them as much help as they need for their child?
Definitely. And so let's say hypothetically, if my organization WIC wanted to do this and we had, let's say, 10 participants wanting to take your curriculum, would we supply the space and let you know in a timely manner, when is your availability, so we can set that up?
So I'm a little sorry, I was typing in the chat my email while you were talking, but I think I understood maybe working together to give those classes, because it can be demanding, depending on if it's one class, 2 classes a week, we can have your staff and our staff, trade off on days to do that. So
yeah, so it sounds like we would supply you with the participants, and we would kind of strategize a way to do it in person, or can we also do this virtually?
Yeah, so we have virtual format, or our program does hold the capacity. We have the Zoom account, the business Zoom account, where we can have, I never tried it before, but I think it's up to 60 to 100 people on a Zoom call. But yeah, we can definitely schedule that, something in person, depending on the buildings, the building space or the office space that you have. I see Tiana's hand raised. I really want to answer a question.
My question's a little different. I guess it's the same. I was wondering about team parents, because I know there's a lot of the schools do team parenting classes. Do you guys offer the nutrition classes for them as well? Because obviously they're going to be new parents, but they're young parents, so their diet is not always going to be perfect.
Yeah.
So is that something you guys are doing? Because right now I'm doing research on revamping our team parenting classes that we used to do. And so I was just wondering if you guys had any material that I could add to that, or if you guys were interested in teaming up on that, since we're already partners technically.
Yeah, we could. I mean, we're always open to partner with anyone and anybody here in the community. We're all stronger together.
I can add a little bit to that though. We specify working with 18 to 59, so adult, but we can also give you UCCE is who works majorly with the younger population. So we could also give you that information, as well as help you in any way we can.
There's loopholes as well.
Yeah. If there's
they could bring their mothers or their parents with them for these classes, and if there's at least 3 adults, we can still give the class. So it's kind of or we could just have your staff the curriculum and your staff can teach them. Whatever we find, we can always find a way to give that education to them.
I like, yeah, I was gonna say, I really like that flexibility, because here at WIC, sometimes we get participants that are homeless and that are minors. So we do offer that affidavit so they can, self-declare. But, in those cases, maybe we can partner up and have a class and have have 2 a facilitator and also a presenter. So that way, you know, you're covered and we have that as well, you know, we can help facilitate that. So
Yeah, you
thank
could even had something. We had something so far as like having, you know, an organization's employees shadow us while we give the class for a series, and and that, you know, technically counts as 3 adults in the class. So there's ways to go around it. It's just, organizing something like this, um, talking it over with my coordinator and administrator, see if it's something that we can legitimately do. If we can't, we'll find a way to give you the resources so you can do it yourself.
I just wanted to add, I know Jasmine, you mentioned our CNAP coming up, and it is actually going to be on October 19th, and it's going to be through Zoom from 10 a.m. to 11:30 a.m. I can also share that link if anyone wants to join that.
Yes, please. Thank you. Adriana, if you can please email me that link, and if you have a flyer, and I can definitely put that in our follow-up email. And I see Diana said, can we too get the information, please? Yes. Okay. So is there any more announcements? I know we have like 6 more minutes. And don't feel rushed. 6 minutes can, doesn't go by that fast. So feel free to share. If you have to run and you don't have time to, stick around, put your flyer in the chat and we'll share that out for you.
This is Lori. I just wanted to say how wonderful it is to be a part of the Breastfeeding Coalition of Kern County. I'm over here in Ridgecrest and kind of on my own now with my private business. And I'm just thankful to all the people part of this coalition. And I really wanted to give a shout out to Jenica, who does the nesting company. She invited me over to see some things and to teach me some things so I can enhance my business and hopefully reach more people. So I will be updating the coalition as those changes occur, probably early next year. I'm going to start offering some classes and website and some other things, but none of that would have happened without being a part of this coalition. So I just wanted to express my gratitude for that. And just, I've been a part of the coalition since it started, since its inception. I'm not sure when that was, because we used to have meetings over at San Joaquin monthly. And but I want to say 10 or 12 or 14 years, I don't know, but a lot of the people are no longer there that started it, but I am just very thankful, and I really appreciate all that you're doing right now as chairman, you and Janet, because the educational things being provided is just outstanding. So I just wanted to applaud and give that shout out.
Thank you so much, Lori. And it really means so much for you to, first of all, giving that shout out, and then second of all, being part of this coalition for, its inception and still being, a part of it. So we really appreciate it. And for those of you that aren't familiar with Lori, she used to be a lactation nurse back in Ridgecrest Regional Hospital. And now she has her private practice. And so it sounds like we have a lot of exciting things coming in the works. So we're excited to hear about it. And I do want to quickly share, because I didn't show it earlier, but this is our Kern County Breastfeeding Coalition resources. So we tried back in January, we took a look at our old one and we revamped it. And we really wanted to include, what services are in person, what services are virtual, is it individual lactation support? Is there a fee? Do you have to be a member? So we try to make that easy to identify. So those that don't have the, the dollar sign, they're absolutely free. The ones that do have a dollar sign, they may be out of pocket, it may be insurance based. But I do want to go piggyback what Lori had mentioned. The Nesting Co. is on this resource guide, and they offer free lactation support groups every Friday from 10 a.m. to 1 p.m. And they, they're available. This is their availability from the last time I checked, but it changes. So have your participants call ahead before they show up in person. I also want to mention there are private lactation consultants here in Kern County. And unfortunately, we wish we had a database that was open to all and had the most updated information, but we're still looking and open to other databases. But as of right now, we're using the United States Lactation Consultant website. So you could have your participants scan the QR code, and then they can put in their zip code and be directed to private lactation consultants in their area. I also want to mention legal aid at work. So a lot of you work with families, and sometimes breastfeeding isn't one of their needs, and they need other help, like for example, paid family leave, lactation accommodation if they do, or even what's it called, accommodations for those that are pregnant. You can go ahead and call this number. Their office is located in Fresno, but they do virtual appointments, and they also have hotlines that you can call. So go ahead and scan that QR code. It's called Legal Aid at Work. If you have any questions, please reach out. If you have any comments or would like, know of a way that we can improve this resource guide, or if things, they're not current, let us know and we'll make those updates. But our time has now concluded, so I'm going to go ahead and stop the recording.